Assalamu alaikum dear doctors. In this video I am discussing a recall communications. So the communication topic is that explain pulmonary hypertension to the ST1 who attended the baby's delivery yesterday. Explain the physiology, treatment and explored the concern that she might have done something wrong leading to the baby's admissions. So here is an agenda also, that is she might be did something wrong. We also include this discussion from this communication. So exam scenario also already I read. Now I am giving the explanations. What happened? Before a baby is born, they do not need to use their lungs to breathe because they receive oxygen via the umbilical cord and placenta from their mother. When a baby is born, they take a big breath or cry and their lungs is filled with air instead of fluid. When the lungs fill with air, the blood vessels which take blood from the heart to the lung open and dilate. And this means that oxygen can be carried from the lungs back to the heart and pumped to the brain and the rest of the body once the umbilical cord is cut. And the pressure inside the lungs and the blood vessels is now low. But what happened? This is a physiological normal. In persistent pulmonary hypertension babies, in this case, there's failure of the normal postnatal fall in pulmonary vascular resistance, which leads to right to left shunting and subsequent hypoxia. What are the causes of this persistent pulmonary hypertension? So the causes are first idiopathic and secondary causes, this including aspirin, NSAID, SSRI, hypothermia, hypoglycemia, polycythemia, perinatal, especially the meconium aspiration syndrome, respiratory distress syndrome, group B streptococcus, pneumonia, pulmonary hypoplasia, congenital diaphragmatic hernia, congenital cystic adenomatous malformation, and maternal hypoxia. So these are the causes of developing pulmonary hypertension. Then features. What the baby develop if pulmonary hypertension? There is respiratory distress in the first 12 hours of life and respiratory failure. Right to left shunt through the PFO and or PDA and cyanosis. There is poor cardiac function and hypotension. Increased pressure in the right ventricle, shock. And now what investigation we do for pulmonary hypertension? The investigation we do are blood CBC, ABG, urea and electrolyte, calcium increases endogenous nitric oxide. Besides that, we also do the hyperoxia test, pre and postductal SpO2, blood pressure imaging including chest X-ray, echo and ECG. Complications. Complication is cardiogenic shock, developmental delay, right ventricular failure and interventricular hemorrhage. Treatment and management. So first, what is the aim of the treatment, and according we give the medicine. So decrease the pulmonary vascular resistance, we give the nitric oxide, HFOV and ECMO. Then increase the systemic blood pressure, we give IV fluids and inotropes. And treat any underlying condition, we give the antibiotics and surfactant. So this is all about the pulmonary hypertension communication. Please do subscribe and share MRCPCH with Dr. Emma Choudhury. Thank you.